Okay, today we'll be dealing with how to approach a case of hematuria. Okay, what is hematuria? Hematuria is nothing but it is detection of blood in the urine, as you all know. And to define hematuria, there should be at least more than 5 RBCs per high power field in an uncentrifuged urine sample. Or when you do a dipstick, you should have at least 1 plus in the dipstick to call it as hematuria. Okay. So how do you approach a case of hematuria? Hematuria could be either a microscopic hematuria or it could be a gross hematuria, or you can tell it is a glomerular cause or a non-glomerular cause, or it could be a transient persistent, isolated versus associated with a proteinuria, or symptomatic, asymptomatic, or painful versus painless. Okay, so already we have defined what is hematuria. It is nothing but more than 5 RBCs per high power field in an uncentrifuged urine sample. Okay, gross hematuria is nothing but you can even see in your naked eyes. Microscopic, it is only visualized under the microscope. Okay, but some causes like it could be transient or could be recurrent. Some transient causes are like during an infection, fever, exercise, trauma. There could be a transient cause of hematuria. Recurrent will be in IgA nephropathy, hypercalciuria, wherein they're passing so much of calcium in the urine. Okay, and Alport syndrome. And Alport syndrome is like give you what is tell you what is Alport syndrome. Alport syndrome is nothing but there'll be a mutation in the type 5 collagen, type 4 collagen, that is alpha 5 chain of a type 4 collagen will be mutated, leading to the nephropathy, glomerular injury, and the nephropathy. These type 5 are this alpha 5 chain of type 4 collagen is also present in your cornea as well as your cochlea, leading to lenticonus as well as your hearing loss. So you will have a glomerulonephropathy and anterior lenticonus and the your sensory urine hearing loss. So there could be because of nephrolithiasis, you can get a recurrent hematuria or benign familial hematuria. So if there is family history of hematuria, think of Alport syndrome, IgA nephropathy, thin basement membrane disease, hypercalciuria, or nephrolithiasis. IgA nephropathy is nothing but wherein like a child will have a URI or a gastrointestinal infection, following which 1 to 2 days, after 1 to 2 days of URI or gastrointestinal infection, child will have hematuria. This is because there will be poorly glycosylated IgA will be produced, and this IgA will lead to autoantibodies against IgA and IgG, which will get deposited in your glomerular basement membrane, causing damage. Okay, so that is IgA nephropathy, which will be confirmed by your kidney biopsy. Right? Then coming to glomerular causes, already I've told you, you can differentiate hematuria into a glomerular cause or a non-glomerular cause. Okay, coming to glomerular cause, what are the glomerular cause? Either it could be a glomerulonephritis, or renal vasculitis, or familial, or systemic. So familial, now only you have seen it's Alport's thin basement membrane and nail patella syndrome. And coming to glomerulonephritis, it could be post-infectious glomerulonephritis, or RPGN, MPGN, membranoproliferative glomerulonephritis, or IgA nephropathy. Some vascular cause of glomerular injury will be your HSP, SLE, and HUS. And some systemic infections even can cause glomerular injury, like your hepatitis B, C, HIV, malaria, and some infective endocarditis. Okay. Some parasitic causes of hematuria will be schistosomiasis. Okay. So this is where so any hematuria can be from the upper urinary tract or from the lower urinary tract. What is upper urinary tract? Upper urinary tract will be, as you know, some parts of you already know the parts of nephron. Parts of nephron will be nephron will be first a glomerulus, then followed by your tubules, PCT, loop of Henle, TCT, and collecting duct, followed by your pelvic calyceal system. Then it goes into your pelvic calyceal system, then goes into your ureter, then goes into your bladder and urethra. Okay, fine. Now, okay. So you should split up into, so the upper urinary tract will be comprising your glomerulus, and the tubule and interstitium will be your upper urinary tract. The rest all from the pelvic calyceal system will be your lower urinary tract. And in that, again, you can differentiate it as glomerular hematuria and non-glomerular hematuria. Glomerular hematuria being post-infectious glomerulonephritis, an infection-related IgA nephropathy, MPG, and HSP nephritis, your Henoch-Schönlein purpura nephritis, okay, wherein you will have palpable purpuras, and then hematuria. Then lupus nephritis, Alport syndrome, nail patella syndrome, thin basement membrane disease, and Goodpasture syndrome. Okay, then non-glomerular hematuria. Non-glomerular hematuria will be from the pelvic cell system, right? So it could be like vascular causes like renal vein thrombosis, AV fistulas, some calculus, or some tumors like Wilms tumor, hypercalciuria, drugs which can cause hematuria or your causing kidney injury, cyclophosphamide, which can cause hemorrhagic cystitis, or NSAIDs, anticoagulants, cystitis, infection of your bladder, cystitis. Okay, can cause hematuria. Okay, so it is glomerular cause and then non-glomerular cause. So we have clinical features to differentiate between glomerular and non-glomerular cause, which I'll be telling it later. Okay, see, this is the difference between a glomerular and an extraglomerular hematuria. See, if there is a glomerular hematuria, the patient will be presenting to you with a cola-colored urine rather than a bright red urine. Okay, so there will not be any clots. It will be a painless hematuria. Usually, glomerulus is injured, will lead to also leakage of proteins in the urine causing proteinuria, and the RBCs will be dysmorphic because the RBCs are passing through the microcapillaries, that is your glomerulus. It passes through your glomerulus leading to dysmorphic RBCs. So our dysmorphic RBCs, that is RBC cast, will be present. Extraglomerular is exactly the opposite. It is the lower part. So it will be bright red in color, pink color, and clots will be there because your glomerulus is not injured. There will not be any proteinuria. RBC cast will not be there. Your RBC morphology will be normal in an extraglomerular hematuria. Right. Again, some painful and painless cause of hematuria. Painless cause of hematuria will be always from the glomerulus. Okay. Like in glomerulonephritis, you will have, I already have told you, glomerular cause will be painless. Okay. Right. In glomerulonephritis, you will have hematuria, hypertension, edema. When you have the triad of a patient presenting to you with a cola-colored urine and edema, and you diagnose hypertension and azotemia, it's glomerulonephritis, obviously. And then some other causes like your IgA nephropathy, lupus can have painless hematuриas. Membranoproliferative glomerulonephritis, FSGS, Alport syndrome. Infection of fever-related glomerulonephritis can also cause. Then your HSP SLE. Suppose HSP SLE will have, what will be the features? Like they'll present with hematuria, there will be skin rashes, joint pains, unexplained fever. Familial hematuria, you already know the causes. Okay, not a painful hematuria. Painful hematuria, think of non-glomerular causes. Your cystitis, calculi. Okay, clots are passing. Then think of cystitis. Abdominal masses are there. Then think of abdominal masses. Think of both Wilms tumor and renal vein thrombosis in a neonate. Okay, then painful terminal hematuria. Think of schistosomiasis also. Then systemic causes like your bleeding disorders, coagulopathy, sickle cell disease. Okay. How do we evaluate a case of hematuria? Any evaluation, you go with history, examination, then your investigations will go with the same. Okay. So before going to history, like some causes for a red colored urine. See, not all red urine are hematuria. So if a patient complains to you, presents to you with complaints of red urine, you have to diagnose whether it is hematuria or it is the discoloration of the urine. Okay. So suppose a patient presenting to you with red urine and you do a urine microscopy, you don't find any RBCs. Then think of the other causes. What are the other causes which cause red urine? Okay, some dyes, beetroots, blackberries. Okay, hemoglobinuria, myoglobinuria can cause red urine. Always think of. Okay, when there is an intravascular hemolysis, the RBCs get lysed and hemoglobin is released in the urine. That hemoglobin is passed in the urine, which causes discoloration. In that case, you will not find any RBCs in the urine, but the urine will be red. So think of hemoglobinuria, right? And then drugs like rifampicin, nitrofurantoin, desferoxamine, okay, hydroxychloroquine, all those drugs causes red urine. And some metabolites like a bile pigment, homogentic acid in case of L-captanuria, malanin, methemoglobin, porphyrin, tyrenosis. Yeah, urines can cause a red colored urine. Okay, so coming to evaluation will be history. Hmm. In history, as per if there is hematuria, as per if it is a transient one or a recurrent one or a persistent one, priming of hematuria, whether it is throughout the day or just that is throughout the urine stream or at the beginning or at the end. Color of urine, whether it is cola colored or a fresh color, to differentiate between a glomerular cause and an extraglomerular cause. Recent vigorous trauma and exercise can cause hematuria. If there is UTI, you will have associated features like your dysuria, frequency, and urgency. If it is because of calculus, you will have a flank pain radiating to the groin. If it is because of a post-streptococcal glomerular nephritis, then you will have preceding pharyngitis in impetigo 2 to 3 weeks prior to hematuria. Then ask history of drugs, exposure to drugs. Okay, so family, these histories you should ask. Definitely you should ask family histories because some renal disorders are occurs in family. Okay, definitely ask for consanguinity as per renal disease, as per deafness and eye disorders. Okay, why consanguinity? So because some disease runs in families, right? And think of like thin basement membrane, Alports, everything. If associated with hearing loss, think of Alports. Nutrial antiphons, cystic diseases, cystic think of ADPKD, autosomal dominant polycystic kidney disease, nail petal abnormalities, think of nail petal syndrome, and if the family history has sickle cell disease, also think of a sickle cell disease in the patient. Okay, this is a triad like eye deformities, that is your anterior lenticonus, kidney you are having glomerulonephropathy, and you have hearing loss, cochlear defect, which means some collagen is affecting everything, which is Alport syndrome. The triad of your anterior lenticonus, your glomerulonephropathy, and your hearing loss is your Alport syndrome, wherein you will have alpha 5 chain of type 4 collagen is mutated. Okay, some clinical pointers. Some clinical pointers like what is fit state, what you will think of. So edema, always think of glomerulonephritis. And IgA nephropathy, MPG and FRC is your focal segmental glomerulosclerosis. There is hypertension, again glomerulonephritis. MPG and FSC is IgA nephropathy. Pyoderma cause, think of post-streptococcal. Glomerulonephritis. Purpura, think of HSP. Skin rash and joint swelling, always think of your autoimmune causes like your lupus nephritis, SLE nephritis, hemoptysis. So whenever you have hemoptysis with hematuria, a kidney as well as a renal disorders, both are affected. We'll think of Goodpasture syndrome. Goodpasture syndrome is nothing but a anti-glomerular basement membrane antibody disease. Okay, wherein this anti-glomerular basement membrane antibody will be present both in your lungs as well as your kidney, leading to hemoptysis and hematuria. So when you have two things, think of Goodpasture. When you have abdominal mass, already you know you have to think of a tumor or a renal vein thrombosis or a polycystic kidney. Upper respiratory signs, think of adenovirus cystitis. Okay, so that time you will have presence of conjunctivitis syndrome, conjunctivitis with hematuria, exercise-related March hematuria, deafness, Alports, nail dystrophy, patellar dysplasia, nail patellar syndrome, injury to genital, think of sexual abuse. Always don't forget to think of sexual abuse when you find some injury in that area, which can cause hematuria. Okay, behavioral disturbances, Munchausen syndrome. Okay, see, this is symmetrical palpable purpura, which has started in the foot and has progressively ascended up to involve the gluteal region. What is this? It is Enoch-Schonding purpura. Okay, Enoch-Schonding purpura, you get a palpable purpura, you will have joint pains, you will have abdomen pain, you will have hematuria, meaning this is a vasculitic disorder. This purpura is because of the vasculitis. Okay? And it is not because of the thrombocytopenia. You will not have thrombocytopenia in inoxidant purpura. Okay. This is pyoderma. The pyoderma. If you find a child with pyoderma, they're coming to you with hematuria, think of post-streptococcal glomerulonephritis. Okay, some clues. Actually, we have dealt with all the clues here, like UTA, everything. I'll deal with only what we have not done. Okay, a child presenting to you with a diarrhea in the history of bloody diarrhea in the past. Now presenting with oliguria, anuria. Okay, think of anemia. Think of HUS, hemolytic uremic syndrome. What is hemolytic uremic syndrome? The term only you can tell hemolytic. Okay, so microangiopathy, hemolytic anemia will be there, uremia will be there, and then thrombocytopenia will be there. That is HUS. Okay, okay. Yes, everything we have done. There is anything to be told, I'll do it. Well, everything we have done. We'll proceed to the next. Next, okay, then examination. Any child presenting to you with hematuria, blood pressure needs to be checked, hypertension needs to be removed. If there is hypertension, think of glomerulonephritis. Okay? And edema will be there in glomerulonephritis. If there is associated skin rash, think of SLA, which is pain. Always examine the abdomen for the mass. If there is mass, think of a tumor or a renal vein thrombosis. Okay, this is a classical SLA rash or malar rash, right? Okay, what you do? Next, you go for investigation. First, you confirm whether that urine is hematuria or not. You do a urine microscopy and find out. Okay. Then you find out if there is any pyuria. You diagnose if it is UTI or not. Okay. Then you see whether casts are there. Casts are seen only in the glomerular disease. Okay. To see proteinuria is there. To find out even if it is glomerular cause or not. Okay. And then also check for hypercalciuria with the hypercalcemia, which can cause microscopic hematuria. These things should be seen. Okay, so to find out hematuria, you do a urine dipstick. Urine dipstick, if you get more than 1 plus, think of hematuria. When urine dipstick is positive, it can be hematuria, it could be hemoglobinuria, it could be myoglobinuria, it can be anything. So to differentiate that, urine microscopy should always be done following a dipstick test to confirm hematuria, right? False positive, that could be dipstick, false positive, and false negative. When it could be false positive, that is, there will not be any hematuria, but your dipstick will be positive, meaning you will get an alkaline urine and contamination with oxidizing reagent. False negative, that is, you have a hematuria, but your dipstick is turning out to be negative. Okay, for high urinary concentration, your ascorbic acid will lead to false negative. Okay, so you should always confirm the urine microscopy. Urine microscopy, gold standard for microscopic hematuria. So this is one of your urine microscopic finding. You have RBCs in the urine, which is not deformed, which means there is no cast, no dysmorphic RBCs, meaning it is a non-glomerular origin. Okay. There you can see a dysmorphic RBCs. Okay. This dysmorphic RBCs, RBC cast, meaning it is of glomerular origin. Okay. Dysmorphic RBCs are seen in glomerular cause because it passes all through your microvasculature capillaries. Okay. So already we've seen this, but just the recap. Okay. Glomerular hematuria will have cola colored urine with proteinuria with a dysmorphic RBCs, RBC cast. Non-glomerular will be bright red in color. Proteinuria will not be there. RBC casts not be there. RBC morphology will be normal. Okay, so then you do a basic urine microscopy is over. Then you do some basic investigation like your CBC, RFT. CBC, what do you find? You can find anemia, because anemia can be because of the two reasons. One is intravascular hemolysis leading to hemoglobinuria causing red urine. Could be because of that, or it could be because of the renal failure causing anemia. Okay, hematuria which has led to anemia. So it could be any cause, either of the cause. If associated with thrombocytopenia, think of hemolytic uremic syndrome. Okay, anemia thrombocytopenia. Peripheral smear to rule out hemolytic uremic syndrome. In HUS, you will get microangiopathic hemolytic anemia. So C for cardiac, because it is a renal disorder. C for electrolytes and serum albumin, because proteinuria can cause hypoalbuminemia. So you do some specific tests to diagnose what is the cause for hematuria. You do a complement test, that is your C3 and C4. Like the C3 will be reduced in your acute post-infectious glomerulonephritis. Okay, your C3, C4 both will be reduced in case of lupus nephritis because it is a complement-mediated disorder. So in acute glomerulonephritis, your C3 will be reduced. That C3 C3 will be reduced. That C3 will be reduced for some 6 to 8 weeks. Okay, almost 2 months it will be reduced, and it will recover. Okay? It will not be reduced throughout. It will recover in 6 to 8 weeks. Okay, the best you'll have C3, C4 reduced. Okay, so you have to test for antibodies like ISO anti-DNase B to check if it is post-streptococcal glomerulonephritis. You do ANCA and ANE to diagnose if it is lupus nephritis. You do anti-GM, GBM when you suspect a Goodpasture syndrome. You do urine culture to diagnose UTI, that is pyuria or bacteriuria. Okay, then you do USG abdomen to find out if there is structural anomalies, stones, or polycystic kidney disease, cystitis. CT scan of kidneys, you do to diagnose some tumors or stone or calculi. Okay, then at last you have to do biopsy to find out the cause. In all hematuria, you don't do biopsy, but there are indications where you do biopsy for a renal disorder. Okay, so in acute glomerulonephritis, like if it is PSGN, you are not going to do biopsy. Okay, as in when the child is going to improve in a short period of time. If it is post-streptococcal, if the glomerulonephritis is because of the other causes, there will be progressive renal failure, progressive hematuria. That is when you are going to do a renal biopsy. So, in acute glomerulonephritis, when there is a progressive renal failure, okay, and the hypertension is beyond 7 to 10 days. There is gross hematuria, which is going beyond 1 month. Microscopic hematuria going beyond 1 year. Okay, so usually in post-streptococcal, C3 will be reduced for just 2 months, 6 to 8 weeks. Okay, when it is persistently low beyond 12 weeks, then you do biopsy. At the presentation only C3 is normal, which means it rules out post-streptococcal glomerulonephritis. Then do a biopsy. The persistent protein that you do, and when there is when the presentation only, they present to you with some lupus like fever, rash, joint pain. You do that. You do biopsy. Okay. And microscopic hematuria presenting beyond 2 years and persistent glomerular hematuria, you do biopsy. Okay. So this I've already told for everything what you have to do. HSP. HSP I have not said. If it is HSP, you do a skin biopsy to diagnose Henoch-Schönle purpura. Okay. Yesterday I have told Alports. You do audiogram and slit lamp examination of the eye. And that's it. Okay. And then IgA nephropathy, you do a biopsy to rule out IgA nephropathy. Goodpasture anti-GBM. Okay. Vaginous ANCA. Okay. Okay, this is how you evaluate a case of reclusion presenting to you with red urine. This is very, very important. So, when a patient comes to you with red urine, first you find out it is true hematuria or not. That is how your approach will be. Okay, if it is true hematuria, there's going to be more than 5 RBCs per high power field in an uncentrifuged urine. Okay, if at all there is no more than 5 RBCs, you term it as no hematuria, no red cells. Okay, if okay. If it is, you are found out as hematuria. Second step will be you find out if it is a glomerular cause or a non-glomerular hematuria. Glomerular hematuria meaning you will have colloidal urine, red cell cast, dysmorphic RBCs, and a proteinuria. Okay, non-glomerular, you will not have all those things. You have found out it is glomerular. Glomerular cause, then think of isolated renal disorders or multisystem. If you think of multisystem, then you think of lupus, HUS, and vasculitis. If you think of glomerular cause, isolated renal disease, then think of all your kidney disorders, right? Your post-infectious glomerulonephritis, I told you, only C3 will be low. Okay, and that will recover in 6 to 8 weeks. Post-membranoproliferative glomerulonephritis, HIV nephropathy, okay, hepatitis B and C, okay, IgA nephropathy, all post-thin basal membrane will be glomerular hematuria. Non-glomerular hematuria, think of the lower causes. Okay, do imaging. Next step to in glomerulus, you have to do an imaging and find out it is because of polycystic kidney disease, renal vein thrombosis, interstitial nephritis, renal allograft rejection, or it was because of UTI, urolithiasis, bleeding disorders. Okay, there is no hematuria, then it could be either the dyes, which is discoloring your urine, or it could be a myoglobin or hemoglobin. Do a dipstick. There's no RBCs, dipstick is positive, then think of hemoglobin or myoglobin. Dipstick is negative, then think of the other causes like your dyes, which is discoloring your urine. Okay. So how you are going to treat hematuria? Okay, it is nothing but if it is infection related glomerulonephritis, it is a purely supportive care, fluid, salt restriction, antihypertensives. If it is because of UTI, give antibiotics and treat UTI. If it is because of hypercalciuria, what you do for hypercalciuria? You give thiazide, you increase fluid intake, restrict sodium and thiazide diuretics. Okay. And IgA nephropathy is you have to go for immunosuppression. Renal vein thrombosis, heparin. If it is because of the tumor, like Wilms tumor, you go with chemotherapy or without surgical excision and a radiotherapy. Okay. Follow up for hematuria, hypertension, and proteinuria. Thank you. So we'll brush up regarding hematuria. A quick recap. See, first a definition. Okay. So microscope, like hematuria is nothing but presence of RBCs, more than 5 RBCs per high power field in an uncentrifuged urine is hematuria. Okay. Whenever a child presenting to you next, that is hematuria. So how do you approach? There are so many causes. Either it could be because of the upper urinary tract or lower urinary tract cause, or it could then you can differentiate between a glomerular cause and non-glomerular cause. What we've already told, the glomerular causes. Glomerular cause will be a cola-colored urine with proteinuria with RBC cast and dysmorphic RBCs. Okay. Extraglomerular will have a red color urine with the clots. Proteinuria will not be there. RBC morphology and cast will be normal. Okay. So this is how you. So whenever a child presenting to you with red urine, you diagnose first it is hematuria or not. If it is hematuria, think of whether it is glomerular cause or not. Okay. Then you decide what to do. Okay. So non-glomerular, go for imaging and find out the cause. If it is glomerular, think you do C3 to diagnose. C3, you do C3, C4 to diagnose what it is. If there is no hematuria, you deal with positive dipstick and you find out if there is hemoglobinuria or myoglobinuria. If it is negative for dipstick, then you diagnose if it is because of some dyes. Okay. So thank you so much for listening to this video and we'll end our video here. Thank you.